Hello and welcome to TPA Talks. I'm Danielle Boxall and today I'm joined by a panel of guests to talk about our latest research paper. It's an important and timely analysis of health expenditure and financing across Europe. Healthcare spending in the UK is only going up with every budget and the NHS is an untouchable national treasure. But is it due for some much needed reform? Today we'll be giving the NHS a check-up and comparing it to the other healthcare systems across Europe. We'll be discussing how to get the most value for money from the NHS and if it needs a vital shake-up. On the panel with me today, we have Darwin Friend. Now, Darwin is a policy analyst here at the TPA. He's the author of the paper, and you can find that on our website, taxpayersalliance.com. We're also joined by Kristian Niemietz, who is the head of political economy at the IEA. Before that, he was their head of health and welfare, and he's also the author of Universal Healthcare Without the NHS. And we've also got Matthew Lesh joining us today. Matthew is the head of research at the Adam Smith Institute, and he's written numerous papers on healthcare. Now, before we start, I'd just like to stress that the paper looks into healthcare spending using data from 2017. So I'd like the discussion today to place an emphasis on the situation in healthcare before coronavirus and what we could do to reform the healthcare system after coronavirus. So with that in mind, let's kick things off with a short opening statement from our speakers, beginning with Darwin, who is going to tell us a little bit more about the paper itself.
Thanks very much, Danny. So I just want to start by setting out why I think this is such an important debate to be having now. The Department for Health and Social Care budget is set to rise by £33.9 billion a year by 2024. Meanwhile, our ageing population is growing and the coronavirus pandemic is ongoing. This means that more of taxpayers' money is going to be used to try and tackle these issues. It was for these reasons that we at the Taxpayers Alliance carried out an analysis of health expenditure in OECD countries by using pre-COVID-19 statistics. The countries we selected in this analysis were Germany, France, Sweden, Ireland, the Netherlands, and the UK. And by comparing healthcare spending and performance across these countries, it shows a number of areas for improvement within the UK health model. And it suggests that while the NHS is held in high regard in the UK, it perhaps isn't quite as good a value as taxpayers think. The paper brought up a number of areas for improvement within the UK health model. To start with, there was out-of-pocket expenditure. This was spending which would include, for example, the prescription charge, which means that taxpayers have to dig further into their own pocket in order to pay for the healthcare goods and services they need. This is alongside the payments that they already make to their country's primary health scheme. For example, in the UK, we pay national insurance, which partially funds the NHS. Despite this, the UK bore the greatest share of out-of-pocket spending across our selected countries, with it accounting for 16% of total healthcare spending, or £33.6 billion. Meanwhile, France, which operates a social insurance model, had the lowest share of spending across the entire OECD, with out-of-pocket expenditure accounting for only 9%. But it wasn't just about spending either. Resources mattered too. And once again, insurance-based models outperformed the UK. France and Germany had over 1,000 more hospitals each than the UK, and the Netherlands had 32 hospitals per million of the population to the UK's 29. But I think most importantly for taxpayers, and of course for patients, are health outcomes. But once again, the UK fell short here across a host of different measurements. I'm going to mention just two. The UK had the lowest life expectancy amongst the 6 countries, and Germany the second lowest. This is despite these countries being the smallest and largest spenders on healthcare, which goes to show that just spending more money on health isn't going to solve the problem. It is a bigger issue than that. And when we look at avoidable mortality, the UK had the largest number of deaths per 100,000 of the population. Even countries which use a similar healthcare model to it had significantly fewer deaths. Ireland 16 fewer, and Sweden 47. So of all the disadvantages I've mentioned, this is without a doubt the most important. But it wasn't all bad for us here in the UK. Our model was actually surprisingly good at keeping costs down in areas. The most notable being administration, where we spent the least amongst the selected countries at £32 per person. Ireland and Sweden also performed well here, which all supports the OECD view that tax-based systems are simply better than insurance-based ones at keeping administration costs down. And this then followed on to medical goods, where the UK again was the lowest spender. This may show that the UK is particularly efficient in procuring medical goods, especially compared to insurance models, for example, where Germany spent over double the amount the UK did per person. But it wasn't just about spending either. Savings either. The UK was the largest spender on preventive care. This may be a particularly good area for the UK to target spending on, as it could reduce the long-term costs of health to taxpayers. And finally, I just want to sum up by saying that, of course, there are disadvantages and advantages to the UK model, and we're not unique in that sense. Every country and its health system faces disadvantages. But I think given the data that's revealed in this paper, there does at least need to be a debate in the UK about how we deal with these disadvantages within the current health model that we have. And by doing so, we're not only going to ensure our health model is the best it possibly can be, but we'll ensure that taxpayers and patients get the best possible value for money.
Thank you for that, Darwin. Right, should we go to Kristian to hear your opening thoughts, please?
Sure, thank you, Danielle. First of all, I'm glad the TPA is moving into that territory, because I've been trying for years, and admittedly not very successfully, to broaden the debate on healthcare a little bit. And I can't claim that I have made many friends trying to do this, and I guess you will not either. It's a tricky area for people on the, broadly speaking, the pro-market side, the side of people who believe in market-based solutions. It's pretty much a lost cause for us. It's something where we cannot win, but it's nonetheless an area, a debate which we cannot avoid either, simply because there is such a strong emotional attachment to the NHS. That means that if you believe in market-based solutions, your opponents will always use the NHS as a stick to beat you with. They will always claim that that you are a bad person, that you want to sell off the NHS to Donald Trump, and ideas of that kind have been around for decades, except that the baddie in previous decades wasn't Donald Trump, but it was some other conspiracy theory. But it's always been a thing. This idea that that if you believe in market-based solutions, you want to take healthcare away from the poor, and it's something that your opponents will hold against you anyway. You can't get out of the debate, so you might as well be proactive and actively say, look, these are the sort of models that I have in mind. These are the sort of models that exist, and there are plenty of alternatives to the NHS. There's nothing special about the NHS. Plenty of other countries have managed to achieve universal healthcare, universal coverage, and some of those systems achieve pretty good outcomes. So there's no reason to be especially protective of the NHS. There are plenty of good alternatives out there, and a lot of them are actually across the board, or almost across the board, better than the NHS. That's one point where I would have been far less diplomatic than Darwin has been in his paper. The paper is very balanced, and there's a lot to be said for that. But I would have been, I would have made clearer that actually, if you compare healthcare outcomes as opposed to population health, there the NHS is quite clearly behind most comparable countries. It's not necessarily the case on measures of population health, on life expectancy and healthy life expectancy, measures of that kind, things which are influenced by lifestyle choices and economic, environmental factors and so on. But if you look at things that you can specifically attribute to the medical system, such as the survival rates for the most common types of cancer, survival rates for strokes and heart attacks, and measures of that sort, there you will find the NHS is pretty much always somewhere in the bottom third in rankings of developed and upper middle income countries, usually about on a par with the Czech Republic and Slovenia, behind most of Western Europe and developed countries elsewhere, so certainly behind Australia, Japan, Canada, and so forth. And in that sense, it's clearly not a great way to organize healthcare, and it's not even particularly good value for money. 20 years ago, you could have said, okay, Britain is lagging in healthcare outcomes, but Britain spends a lot less money on healthcare than other countries, so therefore maybe this is simply a matter of priorities. Even that is no longer quite so clear. At the moment, we spend about 8% of GDP on publicly funded healthcare. So that's mostly the NHS plus public health and a couple of related functions. And if you add spending on dentistry and other things that are mostly paid for privately, then that takes us to just over 10% of GDP now. That's by no means an exceptional figure. That's pretty much bang on in the middle in Western Europe. Some spend more, some spend less, but there's absolutely nothing exceptional. It's not even that you can say, okay, you get what you pay for, and we don't have great outcomes because we underspend. Even that is no longer the case. The reason why I think this could be an interesting area for, I mean, it's not a classic TPA topic, healthcare, but I guess one reason why this could be of interest to a TPA audience is that in other systems, even if the amount of spending is more or less the same, it does make a difference whether that is tax money, something that goes to the government and then is spent according to government priorities, or whether you have, as you have in insurance-based systems, entities that are more or less independent of the government, and where healthcare is not politicized to the same extent that it is here. I think that would make a big difference to a lot of people, knowing that the money they spend on healthcare really does go directly to a healthcare financing agency, goes directly to healthcare providers then, and not to the government, and just decoupling it from politics is something that would be worth thinking about.
Okay, thank you, Kristian. And finally, we'll go to Matthew for your opening thoughts.
Well, thank you very much to the TPA for the invitation, and congratulations to Darwin and the TPA on what I think is quite an important report. I think the key point here, and something that isn't really made particularly well in the UK, is that there are various models for funding healthcare. I think, as Kristian knows too well, the debate in the UK can often be quite narrow. It's either the NHS model or it's a very straw-manned version of American healthcare funding. And quite practically, no one in the UK is advocating American system. I think Kristian has spent years and years talking about social insurance models of healthcare and how the outcomes are often better. There are also other models all over the world. I mean, this report focuses on Europe, but of course, the Asian countries use different models again for funding healthcare. I think something like Singapore that has savings accounts, or Australia that has kind of part NHS system and part privately funded, but kind of state subsidized health insurance system. In any case, to me, I think what the most important question is when thinking about healthcare is all about outcomes, because I think we often get obsessed with inputs. We hear at every election how the government's promising more money for healthcare. Occasionally we hear something about outputs, so we'll hear about how many hospitals are being built, but we just don't enough talk about what are the actual patient outcomes. And as Kristian has said, they often end up being quite mediocre in the UK and under the NHS. And there's just no reason to think necessarily that putting more money into the same system will deliver better outcomes. It can often be a ginormous black hole. I want to just, though, in my opening remarks, just move us a little bit on to thinking about the pandemic and what we've learned this year about the UK's healthcare system. It's been claimed again and again that the UK has been left ill-prepared for the pandemic because of holding out of public services and lack of funding of healthcare. Now, as we begin with, of course, that is a myth. There has not been a reduction in the last decade on NHS funding. In fact, despite reductions in other areas of government spending, the NHS was always protected, and the same with infectious disease spending, as Christopher Snowdon has pointed out. But in any case, it's worth stepping back and thinking, are countries that have put more money into healthcare systems and generally some more healthcare actually done better in the pandemic? And the answer, I think, is quite clearly no. The countries that have been most successful in responding, at least very initially, the pandemic, and I think in an ongoing way, are countries like the Asian tigers, that all actually have relatively low levels of healthcare spending, but small and agile bureaucracies, and they were willing to take decisive early action. So if you think of something like Singapore that has practically no COVID cases and extremely small number of deaths, they spend just 4.5% of GDP on healthcare. Now that's less than half of the UK. Taiwan sends 6.1%, Hong Kong 6.2%, South Korea 7.3%. What these countries did quite well, and in fact, they didn't instigate lockdowns, but they did put in place early warning systems to ensure that they could identify early cases of new viruses. They had very good testing, tracing, and isolating systems. And they also had very good education about things like hand washing and mask wearing and medical treatment. And I think what that shows you is that when it comes to a pandemic, if you want an effective response, it's not about necessarily throwing money at the system. The UK has spent something like £12 billion now on its test and trace system after early failures when it came to a highly centralised public Health England run system that was just a cataclysmic failure. Now, unfortunately, the government never really learned because the new system they set up was still highly centralised. They didn't properly use contact tracing capacity throughout the country. They centralised testing to a relatively small number of mega labs, and that's been a colossal mess. And it's also been a very expensive mess as well. And it's doubtful that despite all that money, that it's had a huge impact on the pandemic. If you think about somewhere like Germany, it spends a few percentage points more than the UK on healthcare, but of course they use a social insurance model. They have a very decentralized system of healthcare delivery, and that meant that when the pandemic came, they had a very decentralized system of testing and tracing, and that's proven extremely effective. I think Germany's probably one of the best, if not the best, large country in Europe when it comes to properly testing and tracing and isolating COVID cases. So again, I think the obsession with the amount of money can often distract from more important conversations about how you structure a healthcare system, about ensuring good patient outcomes. And often in the UK case, everything through the NHS and through the state is extremely centralised. And that's a key failure again and again and again you see across all different sides of this pandemic. So for example, with care homes, you saw the government discharging and the NHS discharging through a national policy, people into care homes untested. That was a national policy. So rather than thinking locally and thinking about what different care homes can handle, I'm sure some care homes could isolate patients, but most can't isolate patients if they're COVID positive. Perhaps you want to send them somewhere else where they can isolate. These kind of very localized micro questions that can't really be answered at a national level are the kind of conversations we need to have. But I don't think we can really have it if we're so narrowly focused on one model of healthcare and one model of healthcare funding. And that's why I think this report is a very important contribution.
Okay, thank you, Matthew. Lots to think about there, and I'm sure we'll come to the sort of effects of COVID and what we've learned from the coronavirus so far a bit later on. But first, I'd just like to sort of dive into the different systems. And Darwin, I'd like to ask you a couple of questions about what the different systems are, how they work. So obviously we know the NHS in the UK is a sort of centrally funded system, and it's quite similar to the systems in Ireland and Sweden, which is two other countries that you picked out for the paper. You also looked at Germany and France. Could you explain how they're funded and what sort of system they've got there?
Sure. So when looking at the revenues of healthcare systems, as you mentioned, Ireland, Sweden and the UK are all fairly similar. That's all pretty much predominantly through public revenues. So in the UK, 79% of revenues raised or revenues spent were raised publicly. Sweden slightly more on 84%. So that's generally how that works. It's quite simple. When it comes to insurance-based systems, it's slightly different. So Germany and France, for example, have a base level of spending which is raised publicly. So that could be through earmarked taxation potentially for healthcare, but the majority of it, so in Germany, for example, it was almost 64% of revenues were raised from social insurance contributions. Now that makes sense because they've got a social insurance healthcare model. But then we've also got the Netherlands in there as well. So they run quite different actually to all the other countries. They have a dual financing system really, whereby just over 50% of healthcare is financed by private health insurance, which is mandatory. So similar to social insurance contributions, people make private insurance contributions. And then they also have a level of social insurance as well, which is mainly for long-term care, which is financed by general taxation as well. So it ranges, but in each system, there is a form of general taxation, which provides a level of care.
Okay, Darwin, you mentioned this other system that they have in the Netherlands. I'd like to get the other panelists' perspectives on this, because you both mentioned the sort of benefits of having this social insurance model that Germany and France have got. But what do you think about this sort of Dutch model and the benefits that might have? Kristian, let's go to you first.
Yes, well, I would classify them a little bit differently. I mean, there's no standard taxonomy here. You can do it in different ways. But I say that the big distinction is between systems where you have one single state insurer, like in France and in Canada, and systems where you have competing multiple insurers, like in Germany, like in Switzerland, like in the Netherlands. And I would classify that as very much the same type of system. The distinction between social insurance and private insurance can be a bit illusory, because social insurance really just means that that the insurance premiums that you pay are not related to your individual risk. So unlike in conventional private insurance contracts, it's not that somebody who is in worse health, somebody who has pre-existing conditions or whatever, pays more for that. It means that your contributions would be standardized and independent of risk. That's what social insurance means. But a social insurance operator can be a private company. There's no reason why they shouldn't be. And it just so happens that in the Netherlands, that is usually the case. Whereas in the German case, for historical reasons, they're mostly cooperative organizations, but it's a different historical origin. But I would see them very much as part of the same family of systems. So social insurance means you can choose between competing health insurers, and they can be substantially different from one another. And you can also choose between different healthcare plans. You have that level of consumer choice, and that offers you something that you just couldn't get in a system like the NHS, where even if the government wanted to replicate that somehow, I don't see how you would do that. The idea that you can choose, for example, between a healthcare plan where you have a gatekeeper model, you have to go to your GP first before you can go to a specialist, or a healthcare plan where you can go directly to specialists. And it's just up to you whether you want that freedom of direct access, and whether you're prepared to pay a bit extra for that, or whether you're okay with that more basic model where your provider choice is a bit more restricted. And if you would rather have the premium reduction, that's the sort of freedom of choice that you can get in a system with competing insurers and competing healthcare plans. And that's something which neither the NHS can do, nor a system with a state monopoly insurer like in France. I'd say that's the big difference.
Okay, and Matthew, have you got any thoughts on that, on the sort of differences between the sort of German, French, and then maybe the Netherlands system? Are they as different as we think, or are they still quite similar?
Yeah, I think I just reiterate the point Kristian made, which is in terms of considering what is best for patients. I think it's ultimately about thinking about a system that maximizes choice and competition. So in a sense, the key failure with the NHS is that you don't really get much choice. You can kind of choose your GP, but once it's chosen, you're kind of stuck with them. You got to go re-register with a different GP. You can only call up that single GP. And they've got very little kind of incentive to serve you directly, since you're not paying them, and they know you can't really go anywhere else to get a better service. With some limited exceptions. Let's say something like Babylon coming along gives you a little bit more choice. What the social insurance-based models do, like in the Netherlands or like in Germany, is they give you, the consumer, a lot more choice. With that choice means that healthcare providers have to compete for you and to provide your service, and that increases the quality of it. And I think having a mixed public-private system in some ways helps deliver that as well, because if you have a choice between the public and the private system, I think if people can choose to go private, that actually tends to increase the quality of the public system in two ways. I mean, one, it reduces the burden on a public system if people are paying extra and going to a private system, but it also means the public system has to provide a kind of a decent and high quality service to be able to compete, to make sure that people, a large number of people, don't go to the private system. The way the UK is structured, we have that to some extent. It's just that the private system is so expensive and so inaccessible to a lot of people that it doesn't really put much pressure on the NHS to improve its quality of service. It just means you have, ironically, a highly inequitable system, which is that if you can pay a lot of money in the UK, you can get some of the extraordinary world's best healthcare straight away. If you are on the NHS, you'll sometimes get extraordinary world's best healthcare, but sometimes you won't. You just get very varied quality of service, and you don't really have much choice about the kind of service that you get on the NHS, because it's just not kind of competition in the same way. It's not the kind of choice you can get.
I'd just like to come back on that point about the sort of like market forces in the NHS. There was a sort of movement towards introducing some of these things with a sort of like league table of hospitals and that sort of and how well they were performing. Do you think that really worked out very well in giving people more choice, or making the hospitals compete against each other a bit more to provide better outcomes? Matthew?
And there's been lots of efforts to marketize in the NHS. You know, you have a system of kind of phony prices, and there's clinical commissioning groups, you know, pay 2 hospitals and 2 GP surgeries, and there's a system of apparent market driven, but it's kind of all behind the scenes. You don't really, as a consumer, get a lot of choice in terms of what you want to do within the system. So although you can, to some extent, you can try to choose a hospital, it's the kind of, every hospital is more or less comparable, and you're probably going to go to the one that's physically closest to you anyway in an emergency. So it's not like you've got wildly different qualities of service you can choose from. It just seems to kind of, to some extent, all be more or less the same. And I think that's a flaw in the NHS.
Darwin, can we break down a little bit where the sort of funding, what it goes towards in these different systems? So we've spoken about how they are funded, but what actually happens when they get the money? Where does that go?
So the UK is actually quite different to a lot of other countries. Most of the 6 countries we looked at, they spent around about 50% of their healthcare spending on their primary health financing scheme. So through the NHS in the UK, they largely spent that on curative and rehabilitative care, which is understandable because that's mainly why most people get in touch with their health system in the first place. But the UK actually, quite differently to those, spent 10 percentage points more than all the other countries except for France. So there definitely seems to be a focus in the UK, at least, on spending on curative and rehabilitative care. And then that follows down, and it's also quite similar in the other forms of health expenditure. So on long-term health, all the countries roughly spent the same amount, around about 20% quite often, and then so on and so on down to medical goods. But as I was saying in my opening or my introductions, is the fact that the UK spending is less pretty much across all the functions of healthcare. And that's understandable because the total level of healthcare in the UK is less than the other countries. But at the same time, in certain areas, that's not always a bad thing. So for example, as I was saying, administration costs were low, medical goods costs were low, especially compared to the systems that Kristian and Matthew have spoken about in regard to the social insurance countries, which these typically just have higher levels of administration and medical goods spending. And it's similar again on the fact that preventive care, the UK stood out across all the other countries, no matter what system they used, by putting the most amount of spending into preventive care. So like I say, it's roughly similar to other countries, but the notable exception is curative and rehabilitative care, where we spend significantly more in terms of percentage points compared to other health models.
Okay, I'd like to ask Kristian what your thoughts are about that. You said in your sort of opening that more spending isn't always necessarily a good thing, but the countries where they seem to have better outcomes are spending more money. So is it true that more spending isn't a good thing, or does it seem to follow through?
Well, the trouble is that there are only some outcomes that we can measure. We can measure outcomes where it's a matter of life or death, where you can look at survival rates. But for other things, most of the healthcare that we use isn't about life or death. It's about quality of life. It's about alleviating pain or alleviating discomfort. And there it's much harder to compare outcomes. So therefore, I guess one reason why some other systems are overall higher spenders is that these systems are more generous. They offer you things that you cannot get here or not so easily get. But that is something that we cannot quantify exactly. That's more anecdotal. That's just always, whenever you ask a Western European expat who lives in Britain, when you ask them, what do you make of the NHS? They will always say, well, where I come from, it was much easier to get this or that. Here it's much harder. And that shows the differences in spending levels, that other systems are more generous. And it's quite hard to say whether that's a good thing or a bad thing. That's just a matter of priorities. But that doesn't mean that. I mean, if we're looking at things like differences in cancer survival rates and stroke survival, we would have to look at not overall spending, but specifically spending on those areas, the bread and butter issues. Does the NHS really spend less on that? Or is it just that it spends less overall? I mean, total spending as a percentage of GDP is a massive aggregate. It doesn't tell you how much the system spends on specifically on cancer care, specifically on stroke care and rehabilitation. So therefore, saying, well, this country has higher cancer survival rates because they have more, they spend more in total in terms of percentage of GDP, that would just be too big an aggregate. I have from what I've seen, I have seen no evidence that the NHS spends less on these bread and butter issues. It's just that the NHS is less generous than other systems, and therefore total spending is lower. But you can't say that that is the reason why cancer survival rates and stroke survival rates are lower. It's more, I always compare to, let's say if you compare consumption between a rich household and a poor household. Of course, the rich household has higher expenditure overall, but it's very unlikely that they spend more on bread and milk and eggs than the poor household, because those are things where you just have a basic level of spending, and it doesn't matter whether you're a welfare recipient or whether you're Bill Gates. It's not that you can buy thousands of brands of luxury eggs or whatever. It's just an upper limit. And the same is true, I'd say, for the core functions of healthcare systems. And it's just that some of those European systems spend more on the optional extras, the bells and whistles, and that's why total spending is higher. But it would be wrong to say that must be the reason why they have better measurable outcomes.
But also there's a lot of rationing that ends up going on in the NHS, which is doctors will only be able to order a certain number of tests or CT scans or whatever else it may be. And in marginal cases where it's not really clear what's going on, they might be less inclined to order those tests just because they know that there's limited capacity to get them. They're going to take a while to come back. There's no point doing it. And so you compare that to America, where they spend twice as much as a proportion of GDP, and they've obviously got a bigger economy as well. So they spend huge amounts on healthcare. You're going to get every single test. You're going to get every single scan. You're going to get all those additional add-ons, some of which might be quite helpful. Sometimes they're going to find something that you wouldn't otherwise find, that cancer or that tumor or whatever it may be. While the NHS makes kind of decision to really rationalise use of resources. So occasionally that means that you are saving money for the taxpayer under the system. And I think occasionally that's going to mean you're going to be missing things. And it's hard to know in which cases, which things are going on. I think the biggest case though of rationing we've seen in the NHS, just basically what's happening with COVID, which is the government made an active decision to take from the National Health Service to the COVID Health Service. And that meant both practically speaking that people weren't getting as many cancer referrals. People were either choosing not to go to hospital, or they were discouraged from going to hospital by the pandemic. And this is an issue everywhere to some extent, but I think it's going to be a particularly large issue in the UK, where the NHS could only really do one thing really well. So it could really focus on COVID, and it could make sure all those patients are seen, but then it can't do other things at the same time. And I think that's the kind of rationing you get in the UK system, because there's a relatively lower proportion of spending on it. Compared to, let's say, the US, where you can probably try, at least to some extent, try to do everything at the same time.
Okay, and I want to talk a little bit more about this out-of-pocket funding. So the UK spends the most on post-tax income on healthcare, and that's something that you mentioned in your introduction there, Kristian. Do you think this really has an impact on how people see like the NHS? They're not going to want to move to a sort of social care, a social insurance model if they're already feeling out of pocket, are they?
Yes, we have to look at where that comes from. If you are only an NHS patient, it is possible to spend next to nothing out of pocket. It would really just be the prescription charge. The reason why out-of-pocket spending as a whole can be fairly high, is that there are some things that the NHS just doesn't regularly cover. You can still find NHS dentists, for example, but for the most part, that is now done privately. And these are things that some of the social insurance systems would just include. Dentistry is something that would just be paid for by your health insurer, and a small co-payment. But it's not that you think about the cost of going to the dentist, and various other things. But it still means that your experience as an NHS user, there you almost never make a direct payment, and for a lot of routine healthcare services, co-payments would actually be higher in some of the social insurance systems, and I think that's not a bad thing. I think that's something that we should think about even within the system, to have some co-payments, partly to reduce demand, but also to redirect demand. Ideally, you would have a co-payment that is a proportion of the costs, let's say 5% of the cost, 10% of the costs, but where you would have an active incentive to seek low-cost alternatives. If you have some routine condition where it's really optional, that you don't have to see a doctor, you could just self-medicate or go to a walk-in clinic, to have those financial incentives to do that. And that's something where even the current system could benefit from co-payments, rather than what we have at the moment is an all or nothing system where most services are completely free at the point of use. You never think about money in any shape or form, and then there are some things that are just not covered at all, and you pay for almost all of it out of pocket, and then it can be a substantial sum. But I would rather see more things in between, where we have lots of small payments, not enough to really discourage you if it's a serious case and you really need that healthcare, but enough to make a difference at the margin, when it's a marginal case, where it makes you think, do I really need that, or should I not just go for the cheap alternative?
Okay.
No, we don't pay directly in terms of a co-payment. We do pay in time, though. Because we choose not to ration by asking people to pay a small co-payment, you wait many days or weeks to get to see your doctor. You wait weeks and months to get non-urgent surgery. So because there's no kind of incentive by pay, there is still a cost and a way to ration, which is just in your time.
Yeah.
Okay, and Darwin, what do you think? Do you think it's going to stop people from wanting to move towards that sort of system if they're already feeling like they're doing worse off under the NHS?
I largely agree with what Kristian and Matthew have said, to be honest, actually. And I think the issue is there have been arguments. For example, I know the World Health Organization has said you could one way to reduce out-of-pocket spending would be to almost abolish the user fees for, say, for example, the prescription charge or other forms of care. But the issue is with that is that you're essentially, in the NHS model at least, then just going to shift the costs. So that may then come up under a universal healthcare spending. But if that were to happen, then the government is likely to then have to increase taxes on taxpayers in order to finance that. So I don't think necessarily, as Kristian said, just abolishing, for example, charges or having everything charged is the right approach. Having that mid approach. So if it were the case that, okay, right, well, I've got this prescription charge, for example, to pay. Well, okay, do I necessarily need to pay for that? Perhaps not. Or if there's this elective surgery that I need to have, do I need to have that or not? And if you don't need to have it, then yeah, I think it's fair to have some form of co-payment there. And the Taxpayers Alliance has actually said in certain forms of care, there is scope, for example, to put in some form of co-payment, most notably in adult social care, which is pretty much financed at the minute by local government taxation. So no, I think there's a level of an in-between rather than, as often seems to be the debate in the UK, either or of it's either fully funded by the NHS or it's the poorest people having to spend thousands of pounds for their surgery. I think it's a middle ground that's necessary.
Okay, should we talk a little bit about outcomes now, and sort of moving on from that? One of the areas that the UK does quite badly in is the avoidable deaths, which Darwin, you mentioned in the paper. If we're already putting people off by, you know, sort of having these huge wait times and the rationing of services, and if we move to a different system, would this not put more people off, and it could lead to an increase in avoidable deaths? Darwin, what do you think about that?
I'm not sure about that. I mean, given the level of deaths in the UK, I mean, it was as I was mentioning, it's the highest amongst the countries we looked at 187 per 100,000 of the population. As I mentioned, Sweden and Ireland, which operate a similar model to the UK, had significantly fewer deaths than that. But France and the Netherlands also did too. I mean, the only country that was actually had slightly better deaths was Germany. It had 2 fewer deaths than the UK, but relatively that's still quite similar to the UK. And so I don't think it's the case of if we move to another model, or if we were to suggest moving to another model or partially moving to it, that it would put people off. Because I think if we actually look at the results on the whole of different countries and different systems, whether it be vastly different to the UK or quite similar to the UK as Sweden and Ireland are, I don't think that would put people off, because if you give them the figures, they can easily understand. People aren't stupid, that actually these figures are significantly better. And so we do need to learn whatever lessons we can from those systems, even if it isn't the fundamental change of we're going to move to a social insurance model. I think we need to learn from those models wherever we can about how we can implement whatever they're doing to have such lower death rates than us into our own system.
Matthew, do you want to expand on that at all?
So I just think in terms of thinking about reform of the NHS and potential change, it's worth looking overseas and seeing what works really well, but also remembering at the same time that it's actually very difficult to directly replicate what another country does. They have their own particular historical context, they have their own norms about how that certain policy is delivered, the expectations of the way the policy is delivered, the existing supporters of that system, who be it the doctors and the nurses or the insurance companies or whatever it may be. And it's very difficult for one country to entirely copy another country's system of healthcare delivery. What I think we can do, though, is think about the little, and this is particularly, I think, in the case of the NHS, where the existing system does have such strong support, is thinking about what changes we can make on top of the existing system that might, every one of them each be incremental, but pushing in the right direction towards a more market-driven system of healthcare, but also being relatively humble about it. Because quite frankly, we don't know what trying to implement a social insurance model in the UK would look like, because we've never tried to do that before, and it would be quite difficult to do. And it's not like the UK civil service and bureaucracy has really shown itself particularly capable of introducing policies and doing things in recent history. So we've got to be, I think we should start being relatively, when it comes to healthcare reform, relatively humble and incremental in our approach. Thinking about things that we can do step by step to improve it. One classic idea, for example, is letting people choose different clinical commissioning groups around the country, and therefore turning the clinical commissioning groups into a kind of insurance provider. And I quite like that idea. It is kind of quite radical in a sense, but it's using an existing institutional framework. Every government tries to restructure the NHS entirely, but if we can make key changes around the sides, I think you can begin to see what works and doesn't work, and experiment with different policies and try to achieve and see what actually achieves better outcomes in that process.
And what are your thoughts, Kristian? Would you like to see these sort of incremental changes, or a much more radical change to the system that we have?
First of all, there are examples of radical changes that have worked, namely in the Czech Republic and Slovakia. They have social insurance systems. They had, well, obviously an NHS type system under socialism, when they were the Czechoslovak Socialist Republic. And just after the return of democracy in the market economy, they moved away from that and towards a social insurance system, which they then continued after the split into the two countries, and they have fairly successful social insurance systems today. But that was, of course, a historically unique situation. That was a situation where you can say, okay, well, we have to overhaul the entire economy now. Might as well overhaul healthcare while we're at it. That's not something that you can directly replicate here. No, I think in practice, it would be, even a radical reform would only play out incrementally. What Matthew talked about turning the clinical commissioning groups, the local NHS organizations, into effectively insurers. That's something that I've suggested as well in my book on that. That's something, if you did that, on the first day, pretty much nothing would change. Everyone would still be with their existing clinical commissioning group. They would have a legal status, a different legal status now. They would now technically be social insurers rather than clinical commissioning groups. But for you, this wouldn't make a difference. You would just get a letter from them saying there have been various changes. If you're happy with the way things currently are, do nothing. There's nothing you have to do. However, if you want to, you can now choose a different clinical commissioning group, or you can choose a private insurance company as well. You can make different choices now, but you don't have to. The default option is do nothing. Lean back. We're not forcing any change on you. And if it then turned out that most people are actually quite happy with the way things are, then even if you had such a change, nothing much would change in practice. But I guess that over time, people would make different choices. And then after maybe 10 years on, the system would look a lot more like the system in the Netherlands, like the system in Switzerland. You would then have a competitive social health insurance system with competing insurers, competing providers, and you could then liberalize lots of other things alongside. You could liberalize the relationship between health insurers and providers, have things like selective commissioning, where one insurer has a selective contract with particular providers, where they use a different payment formula, try to do things differently, experiment with different types of incentives, and things would change then quite a lot, in the sense that you would get a competitive marketplace with experimentation and different organizations, different companies doing things differently. That would all come in, but it's not like the Thatcherite privatizations of the 80s that suddenly you shake up the entire economy. It would be more like you introduce additional options, but on the first day nothing changes. It would not feel to anyone like one system has just been abolished and a different system has been introduced. It wouldn't be like that. It would just be change that starts slowly and would maybe gather momentum, and a decade from that reform, things might look quite differently. But on the first day, everything would still be pretty much the same. And if you don't want to change anything, you don't have to. And that's more or less the way it worked in the Netherlands. They always had a social insurance system, but it wasn't always the market-driven competitive system that they have now. They used to have a system where, even though they had multiple insurers, they all did more or less the same thing. So in practice, you had very limited competition. In practice, you had very limited market mechanisms in that system until 2006. And then that was all liberalized, and the insurers were given a lot more freedom to offer very different types of healthcare plans, for example, and have very different arrangements with healthcare providers. But if you just ask people who lived through those changes, how did it feel to you? 99% would probably say didn't notice it at the time. They would say yes, and looking back now, we can now say that healthcare is now quite different from the way it was 20 years ago. But it's not like the Dutch population woke up one morning and realized, oh God, the healthcare system is totally different. It was in practice incremental.
I just wanted to say something quickly there, just on what Matthew and Kristian said, was just, of course, we're talking about incremental or substantial change over to an insurance-based system. But one of the main negatives that not just, or not my study has found, but numerous others, for example, by the Commonwealth Fund, has found that even though insurance-based countries such as Australia performs very highly on pretty much every other ranking level, where it performs poorly is equity. And this is something which obviously the UK model, being a national health service, is substantially different. It typically performs highly at that because the service is the same for everyone, no matter your level of income. So I was just curious in terms of what they both thought in terms of, if we were to do this incremental change that they're suggesting, how do we ensure that those that for example, the poorest or those in poverty, for example, don't suffer the consequences of potentially high co-payments in comparison to their level of earnings?
Well, I'd say if you're specifically what we're talking about in terms of having a competitive system of clinical commission groups, every commissioning group would have a certain kind of base level of care. And I think the competition between them would rise all boats. So even if you choose to stay with your existing commissioning group, the fact that other people are moving around will put pressure onto your commissioning group to improve the quality of service. Now, would that potentially lead to a gap? Would there be really fantastic commissioning groups and slightly less fantastic commissioning groups? I mean, it just makes me go back to a classic Thatcher metaphor here, which is, I know, I'd personally rather the poor were a little bit richer, even if the gap was a little bit like up here rather than what it currently is. It's a small gap down here between the top and the bottom. If we move up to here, I think that's a good thing. So even if there's a slightly higher gap between, and as I was saying at the start anyway, I think there is a pretty big gap between people who do have a completely private experience of healthcare in the UK and those who don't. So those at the very top, the creme of creme, get very good healthcare. I think if we can push more people up into that higher level at the same time as rising healthcare, for the average, I think that would be a fantastic outcome for everyone. And quite frankly, I don't care if the gap is a little bit larger, if it means that everyone's better off.
Yeah, it's true that the UK ranks well on this equity category in the Commonwealth Fund. I think they're number one even. But Switzerland is a close second with a very market-driven system. That alone shows, yes, that can absolutely be done. The way they do it is simply they still have a very generous minimum package that all insurers have to offer, and they have to offer that to rich and poor alike. And on that, it doesn't matter how much money you have. Everyone gets that package. If Bill Gates moved to Switzerland or Jeff Bezos, they wouldn't get better healthcare in terms of that basic model. They could purchase additional things. Of course, they could go to some luxury clinic where they have a spa resort somewhere in the Swiss Alps or whatever. But their basic healthcare would be no better than that of somebody who gets unemployment benefit or somebody who works in a low-paid job. For that basic level, there's nothing that's not a thing that where money can buy you more. That's something that everybody gets, and you still have the equity in that way, even in a otherwise very market-driven system.
Okay, and just to wrap up very quickly, I'd like to hear what the panel thinks we've learned from the coronavirus crisis. Has that really put a test on our system? And are there any sort of glaring areas that you think we should address after the coronavirus crisis has hopefully passed? Kristian, should we go to you first on that?
Yeah, I'm a bit cautious there because one of the first things I've noticed when the coronavirus broke out was that a lot of people tried to see that as a confirmation for their pre-existing worldview. So you had Brexiteers saying this shows that we really need national independence, while you had Remainers saying this shows that we really need European cooperation. Everyone sees it as sort of a confirmation for what they already believe, and I try to avoid falling into that trap. It would be tempting for me to say, oh look, the German system has done very well, and that also happens to be a competitive insurance system of the type that I'm describing in my book. Haha, I was right all along. I don't want to make that case. There are other models that have been just as successful or more so. The real star performers during the pandemic have been Taiwan and Hong Kong. Taiwan has a national insurance system similar to France, maybe similar to Australia with the Medicare system. And in terms of outcomes, those sort of systems seem to work just as well as competitive insurance systems. I still prefer competitive insurance systems because I just like the idea of having that choice between competing insurers and competing plans. But purely in terms of measurable outcomes, a system of a single national insurer with lots of private providers seems to be doing just as well.
Okay, Darwin, you found out something quite interesting. The UK spends a lot on preventative care, but that has sort of it's been enlightened by the coronavirus crisis. Could you explain a little bit about that, please?
Yeah, for sure. So the UK spent, as I was saying, the most on preventive care, £124 per person in 2017. But as you were saying, given the current crisis, it doesn't look like preventive care has perhaps done what it should have done. And I think one of the reasons could be because obviously you've got the function of preventive care, and then you've also got the other functions that make that up. So for example, the largest amount of that spending was on education and counselling programs, and then vaccinations and other forms of care, compared to there was nothing spent, for example, on emergency response or disaster relief programs. So I think, like I say, spending money on preventive care is a good thing on the whole, but as we've been saying throughout, there does need to be a targeted approach. There's no point in saying, well, the UK is particularly good at, because we've got the largest preventive care, if another country is dealing with things better. I also just wanted to pick up on, obviously, I agree largely with what Kristian said. I think people have pretty much stuck to their own views throughout the coronavirus crisis. If they didn't like the NHS going into it, they are now still calling for a different system. If they did like it, then they think it's still great. And so I think it's the case of not saying, well, this country's done significantly better than us or significantly worse than us. I think it's just about learning whatever we can, and then as Matt said earlier on, we can't just replicate another system, but I think we can learn from it and then try and implement what we can within our current health model. And so, like I said, I wouldn't say let's just copy this one country, because I don't think any country's perfect. They're not. I think it's just a case of, learning what you can from Australia, from Hong Kong, from Germany, from Sweden, from Ireland, and then, just implementing it so that then taxpayers actually get the best possible value for money. Okay,
and Matthew, you mentioned it in your beginning speech there. Would you like to add anything just to close us off?
Yeah, I mean, I think Kristian is fundamentally right when he says that we can't be too quick to jump to conclusions, especially since we're in relatively early days with this pandemic. In some ways, it could go on for, hopefully it doesn't, but it could go on for a while longer. I suspect so far that this actually will, and ironically, tell us very little about how to run healthcare systems, but it will tell us a lot about how to run public health and pandemic preparedness, which I think are actually quite relatively narrow, not necessarily expensive, but require certain systems to be in place, certain systems to trigger new case definitions when there's unknown illnesses that appear, certain systems for testing and tracing and how to operate those properly, as well as potentially systems you need in order to ensure that if a virus does appear on the other side of the world, that it doesn't come in through your borders into your country. So I think there's some very specific lessons we can potentially learn about public health and pandemic preparedness that are going to be slightly independent of a healthcare system. But if we were potentially what proved most successful in places like Taiwan and Hong Kong and Singapore, and even after the initial outbreak in China as well, and other places that have been relatively successful. And it's the extent to which we can learn to stop, and if we can stop pandemics before they become endemic, that would be much preferable than the current situation we're in, where there is a quite broad spread in a lot of Western countries, but then there isn't a broad spread in some places, which I think tells us that there are different policies and there is different setup to achieve different outcomes. It's just a question of we can learn those specific lessons and replicate them in future.
That's all we've got time for, unfortunately. Thank you very much to my guests, Darwin, Kristian and Matthew, for joining me and providing us with a really interesting discussion. And thank you for watching. As I said at the start, this is a very important and timely topic, and it's certainly not over yet. So if you'd like to add to the debate, please add your comments down below. And we've got an exciting lineup of guests on TPA Talks over the coming months, so you'll want to subscribe so you don't miss out on those. And if you'd like to hear more from the Taxpayers Alliance, our latest research papers, blogs, or anything else that we're up to, you can always follow us on Twitter at the TPA or on Facebook as well, the Taxpayers Alliance. Thank you very much for watching. Goodbye.